Thanks, Owen. Very, very kind for the introduction, and it's my real pleasure to be here speaking on the CHP Symposium on the latest research of drug trials and recommended treatment for COVID-19. I understand that, of course, Mike Eisen has already talked about management of COVID-19 this morning, and there will be some overlaps between my talk and his. Nevertheless, we will be focusing on perhaps from the Hong Kong perspective, and also that how we could further improve in terms of the treatment for COVID-19. So this is my disclosure. Just some introduction, and of course that this is the what happened on 19th of March, more than 9 months ago, when China is very much the epicenter of the pandemic, and then of course the virus has just been spread to Europe and UK and also to US, and of course that the cases at that time was just 200,000. With almost 9,000 mortality, and mortality rate was 4.1%. 9 months later, as of yesterday, 8th of December, then of course we saw that very much different picture now. Of course, the epicenter is very much shifted towards US and Brazil, Russia and India, and of course China and most part of Asia is now relatively contained in terms of the pandemic, and nevertheless, the number of confirmed cases has risen to a staggering 67 million cases with 1.5 million mortality and a mortality rate of 2.3%. And of course, most unfortunate, of course, is US is the highest in terms of the cases, and also followed by India and Brazil. With respect to Hong Kong, of course, if you look at the cumulative cases, US, India, and Brazil is very much up there. China is down in the middle. And of course, that in Taiwan and Hong Kong and Singapore is very much here at the bottom. And of course, the mortality rate is also one of the lowest of all the countries. Nevertheless, of course, we are currently experiencing our so-called fourth wave, right in the middle of our fourth wave, approaching 7,000 of confirmed cases. And then, of course, we experienced the second wave, which is more or less due to imported cases, followed by the third and the fourth wave, very much a local outbreaks. The third and the fourth wave is characterized, of course, is by the mutation of the spike protein of the D614G mutation, which allowed the virus to be much more transmissible. And of course, the fourth wave is currently, is a local cluster due to a large cohort of more than 500 people due to Latin dancing cluster. Nevertheless, when we sequence the virus, it is of the same clade that was identified in late September, which is the Nepalese clade, and causing now a community outbreak among these dancers. And of course, there's a second and third generation of these outbreak. If you compare Hong Kong to New York, is that with a similar size, nevertheless, we are much more densely populated despite having a larger area, because most of our usable areas is so-called our country park. So that's why we are third densely populated in the world. In terms of the COVID-19 confirmed cases, we are approaching 7,000 cases with just more than 100 deaths. Mortality rate is 1.6%, and ICU occupancy, even up to now, is around 50%, which compared to New York, we have more than 700,000 cases there with 34,000 deaths, mortality rate close to 5%, and with an ICU occupancy of 100% for the past, I think, 9 months or so. So this is a huge contrast, and this is probably due to the way we approach the virus in terms of the infection control measures, the surveillance. And this is, of course, important because that allows us to treat the patient, hospitalized patient, and treat the patient much more early on, which is extremely important to the outcome of these treatment trials. And of course, the problem in US is very much due to the leadership, the president leadership, which is a dying vacuum as published in the New England Journal of Medicine as such. So with the new president, then hopefully things will change in the US. Another important matter is, of course, is the lessons that we learned from the past. And of course, it was this picture was taken in 2003. And of course, we see the two important persons there who are leading the fight against SARS in 2003 was Professor K.Y. Yoon and of course Professor Monique Pieris. I was very fortunate to be part of the team. Even I was in the picture. And nevertheless, of course, you look at the two major figures, two leaders. They are probably even now they haven't changed much apart from the hairstyle. But important, of course, is the lesson that we learned from the SARS 2003, and that's allowing us to do much better this time around, 17 years later. And of course, the summer broadening program, which I gave the lecture from SARS to influenza, now of course have to add to SARS-CoV-2. What have we learned? And this is the paper that we published in the Lancet 2003, identifying we were the first team to identify the coronavirus as the cause of the 2003 epidemic. And of course, at that time, the phylogenetic tree of the coronavirus is very much more simplified compared to now, which is extremely complicated in terms of phylogenetic tree. Just looking at the beta coronavirus is more than like 30, 40 viruses there. And of course, at that time, we already published in the Lancet illustrating the phases of these coronavirus infection into three phases: the so-called cytolytic or the viremic phase, followed by the immune control or the so-called the cytokine phase or the inflammatory phase, and then the convalescent phase. Important, of course, is that from that experience, that painful experience that we learned, is that this time around, we have very much more prepared. And hence, if you look at this publication from Nature, and that in Hong Kong, we have very intense surveillance, very tight infection control, and hence we are able to control the pandemic much easier compared to other countries. And of course, these measures, including universal face masking, social distancing, very tight border control and screening, easily accessible diagnostic testing, contact tracing, centralized quarantine, and very, very important is negative pressure isolation facilities, allowing hospitalization for the confirmed. And because of the early hospitalization, that allow us to give the treatment and monitor our patient much more closer. And that is the major difference, allowing us to have a much better outcome in terms of the treatment trials. This is, of course, very important because this is the phases, the pathogenesis model of the COVID-19. And this is essential for the treatment at various stages. If you just look at the severe COVID-19, what happened, of course, is that the virus starts shedding about -2 days from symptom onset. And then, of course, that goes on for much longer. Even for the mild cases, it will go on for about a week, and much longer for the severe cases, up to maybe 14 days. And this is the critical moment when there's virus detection and virus shedding and very high viral load. Beyond that, of course, is the second week, which is characterized by the very high hyperinflammatory phase, which is basically what the complication take place and so-called as the cytokine storm. And then, of course, that will be followed by recovery or death. And if you just look at the first week, this is the critical phase when we should give the antiviral treatment. If you give antiviral treatment beyond that into the second week, then it basically is no use because more or less by that time, the IgG would have developed, the antibody would have developed, the viral load will be relatively less. And of course, that this is characterized by the hyperinflammatory phase, that it probably If you give the immunomodulators in terms of interleukin-6, in terms of the so-called convalescent plasma, will probably be much important in this phase, because the viral replication will not be the importance in terms of containing or treating the complication. And of course, we are targeting the treatment in high-risk population, including the elderly above the age of 65, patients with diabetes, hypertension, cardiovascular disease, or chronic pulmonary or liver disease, or those who are immunosuppressed, who are at risk of developing complication. Now we're going back to the antiviral treatment. If you can't remember what I say during the entire lecture, this is probably the most important slide of the entire lecture, is the principle of giving the antiviral treatment, which I borrowed the slide from Dr. Lai Gangyu, who is also share the same kind of opinion and perspective in the antiviral treatment as us. And this applies to all kinds of respiratory viral treatment, including influenza, including other respiratory viruses. That the most important thing is early commencement of antiviral and possibly a combination therapy. And this is one of the reasons why I think the other clinical trials, including that of probably WHO, NIH, and also many other large trials, are currently missing the point, is that unfortunately, they give the antiviral treatment pretty late from symptom onset in these patients. And that probably related to the difficulties in hospitalizing and allowing treatment to be given earlier because of the infection control measures that are currently adopting in these countries. And the importance is, of course, to give an early combination of antiviral treatment to increase the spectrum of activity, increase the potency, and reduce the resistant emergence. This will lead to rapid suppression of the viral load, and hence able to prevent subsequent complications, including that, of course, the cytopathic damage, the cytokine dysregulation, and of course, the nosocomial bacterial co-infection. And another important point is, of course, is reducing the viral shedding. So early treatment with combination of antiviral is essential to controlling the virus, and hence able to suppress and reduce the subsequent cytokine dysregulation, and able to prevent the complications subsequently. Very early on, in fact, in 2003, we were already doing repurposing antiviral treatment for SARS patients at that time. We know that, of course, it's very difficult to formulate and find a effective new antiviral treatment, which is targeting at that virus, because you have to go through the various phases as of the vaccines go through now, the vaccine trials go through now. So at that time, we are already repurposing medication, including leponavir and ribavirin, for the treatment of SARS 2003. And of course, this is a small study that we did in looking at given patient giving this treatment, leponavir and ribavirin combination, to that of the patient who the historical control, that they have not been given this treatment. And of course, the outcome is better. The clinical outcome is better with this combination comparing to that of the historical control. And of course, subsequently, Dr. Jasper Chen from our group also did study looking at the MERS coronavirus, where they investigated the use of interferon beta 1b, and also that of using the leponavir ritonavir in 2015 in the marmoset model. And that, of course, it's been shown that is able to reduce the viral load in various parts of the marmoset upon postmortem in the heart and the lung, and lead to a better outcome in the marmoset model. And this, of course, subsequently has been adopted and used by the Saudi Arabian group to treat MERS in this combination, which have just been published and with a favorable results. And again, very early on in this pandemic, we were able to do in vitro screening of repurposing drugs and looking at the various kind of interferon beta 1a, beta 1b, gamma interferon beta 1b, alpha 2a, and also that of the very potent remdesivir and also leponavir and also other drugs like favipiravir as the potential of treatment, and also hydroxychloroquine as a treatment for SARS-CoV-2. And what we find, of course, is that we compare the so-called the selective index by looking at the cytotoxic concentration 50 and also the EC50. And by having the CC50 over the EC50, we are able to have the so-called selective index. And from this selective index by Dr. Jasper Chen, we are able to show that interferon beta 1b is probably the most effective of all, with a selective index of more than 1,600, compared to interferon beta 1a, which is with a selective index of just 700. And of course, the remdesivir was 96 and the ponavir 8.8. So they do have some action for the ponavir, albeit very low, and remdesivir is just close to 100 in terms of the selective index. And so with this in mind, of course, we are able to formulate subsequently the triple combination that we use. But looking at the early trials by Professor Chao Bing's group, who is also my good friend, which showing that, of course, that the in this early trial that the loponavir-ritonavir combination had some better clinical improvement compared to control. Nevertheless, again, this group of patients was again late presented, so they were using the antiviral treatment beyond day 9 in this group, and hence may not be able to show the best effect of the loponavir-ritonavir. And similarly, in Peter Hobby's group, it was failed to show the Kaletra with the usual care in terms of mortality in this part of the so-called recovery trial. And of course, that probably again related to the late presentation on the trial being enrolled on late presenters. The other trial, of course, you have already seen from Mike's presentation this morning, is the remdesivir trial using the adenosine nucleoside analog. And again, from Chao Bing's group, which failed to reach this study, although failed to reach the target numbers. 200 odd patient was randomized. And of course, the remdesivir group did show some better in terms of clinical improvement compared to control. Nevertheless, it again failed to reach statistical significance. And in terms of viral load, again, there was no major difference between the two groups. And again, I think this is very much limited by the late presentation and very much limited to the severe group, in which the lung is already very inflamed, and hence the antiviral treatment is not going to work very well. And again, the interferon beta treatment is not going to work in the densely inflamed lung because it is simply not an anti-inflammatory drug. Nevertheless, a different trial from John Bagel's group from the NIH showed different results of a better clinical recovery with remdesivir in this trial with more than 1,000 patients enrolled, with a better clinical recovery of 11 days to 15 days. And of course, the mortality rate is again lower in the remdesivir group compared to the control. Other parameters, of course, including that of the oxygen therapy requirement and also the requirement for high flow O2 or NIV is again lower in terms of remdesivir. Nevertheless, the point, of course, is that the importance, of course, is that, as been said by Mike earlier this morning, is that we're still waiting for the viral load data from this study, which is important for the antiviral treatment trial. For the dexamethasone trial, again, from the recovery group by Peter Hobby's group, again, it was given showing that dexamethasone has some effect, beneficial effect, and reducing the mortality of to 22.9% compared to the usual care of 25.7%, and again associated with a so-called lower mortality. But again, it's been criticized again. The mortality rate is still far too high, with the so-called 22.9% in the dexamethasone group. And again, just highlight the difficulties in enrolling this trial is the late presenters in this patient, and many of them, of course, the lung had been very inflamed, and this, as a result, of course, dexamethasone will have its effect, and this is again not the outcome that we would be looking for, because if you are able to treat these patients early on with a antiviral in combination, then these patients, many of them, does not have to require on the treatment with dexamethasone. This, of course, is the latest WHO solidarity trial of a very large trial, which, of course, WHO had did a really good job in enrolling this patient with a huge trial, more than 10,000 adults from 400 different hospitals in 30 countries, and into like 4 arms looking at remdesivir, where they enrolled more than 2,700 patients, hydroxychloroquine 900 patients, leponavir 1,400 patients, and interferon beta 1A, not 1B, okay, interferon beta 1A with leponavir, some of them with leponavir, against no drug treatment, and the overall mortality is 11.8%. So it's a very ambitious clinical trial, and of course that involve countries in Europe, Latin America, and Asia, and with a very huge trial, and of course with patients from very different age group, although majority is between the age of 50 to 69. And again, of course, that study failed to show a difference in terms of the remdesivir to the control, and of course there are some probably some they say although not significant, some harmful effect of giving the interferon and also 1A and hydroxychloroquine. Nevertheless, as I said, the problem with this study is there's a huge limitation in the heterogeneity with the different countries involved, and of course the standard of the ICU support, the day when the antiviral is given is not stated, and of course there's no it's likely that these patients will be treated as so-called late presenters. So again, it's suffering the same problem that this treatment has been given very late, and hence, if you give high interferon, it's likely to cause more damage than any kind of benefits if you give this drug very late, and maybe triggering an immune response and also worsening of the so-called inflammation as such. Nevertheless, of course, if you look at these elderly group, they have some beneficial effect in terms of interferon. And again, this problem, there's no virological data, no biochemical or inflammatory markers to compare, and hence, and also that many of these countries are from different countries in terms of the ICU support, the day of admission, and how they manage these patients are very much different. So it's very difficult to compare the treatment from this various countries, and many of these drugs are probably not available in certain countries and limited the use, and hence resulting in a so-called a negative result as such. Nevertheless, the WHO did give some guidelines suggesting that the remdesivir should not be used at all, and then of course the only dexamethasone should be used in severe and critical cases based on the result from this trial. Now let's talk about the trial from Hong Kong that we performed very early on during our treatment, during the first and second wave of our pandemic, where we designed this trial based on the in vitro study that we did early on. And we were using interferon beta 1B 8 million units alternate day for 3 doses max, and also Kaletra twice daily with ribavirin 400 milligrams twice daily, versus that of the Kaletra alone for 14 days. unable to give a simply control because of the ethical and the cultural reasons that you will not be. I don't think anyone would like to enroll this trial if you're not given anything for the hospitalization for COVID, especially at the earlier phase in the outbreak. And very important, of course, is that we treat these patients very early on. We are able to recruit them with a median of 4 days from symptom onset. And that, of course, we're able to enroll 127 patients based on these treatment and able to compare the two groups. In terms of the primary outcome, we are able to show that this combination have significantly shorter median time to negative nasopharyngeal viral load of 7 days versus 12 days with the combination group compared to the Kaletra alone group. And this is found to be similar findings in that, of course, in the both the NPS and also in that of in the throat saliva and also in the throat swab group in terms of viral outcome. So the viral load dropped much quicker compared to the control in the triple combination. And the same apply for the clinical outcome in terms of alleviation in the new score and also in the silver score, that it fares better, significantly better compared to that of the control group. We noticed that, of course, the Kaletra has some problem associated with GI side effects with diarrhea and also deranged liver function. Nevertheless, these GI side effects are self-limiting upon stopping the Kaletra by 14 days. And that, of course, that we also look at the NSP5 mutation, and there was no mutation in the treatment arm. So the conclusion, of course, we know that interferon beta 1b is probably the backbone of this treatment. Although Kaletra and also ribavirin did have some actions against the COVID-19, and that, of course, we also explained to Mike's comment that, of course, that the difference, the major difference this treatment trial is that this is we managed to start the treatment very early on in the first week on day 4 of majority of our patients, even though it is a relatively small trial. Nevertheless, the virological data is and also the clinical data is very robust. And that, of course, most of our patients did have some pneumonia, and so they are actually in the moderate so-called severity compared to just a small percentage with so-called mild disease. This is, of course, supported by the other basic science papers, in that, of course, the SARS-CoV-2 induced very low interferon and 1 and 3 levels, and of course, our own publications show similar in the hamster lung model. That, of course, the interferon is very much suppressed by this infection. And hence, if you're able to replace the interferon, you're able to boost kickstart the immune response, especially in the first week, if you can do that very early on from symptom onset. And also another study suggesting that patients who are treatment naive, that in the life-threatening group, they are associated with intrinsic antibody against interferon in the immune system, and hence, again, they will have a low interferon response when they are infected with COVID-19. This is, of course, the study I mentioned earlier on for MERS from Saudi Arabia, showing a positive study that if you give interferon beta 1b and also Kaletra, you are able to associate it with a better, significantly better clinical outcome of a much lower mortality of 23% versus 33% of the 28 days mortality, and also shorter ICU stay and hospital stay. The drug was given, of course, much early on day 7 compared to day 7.5 days, still very early on among the two groups. And of course, the median days to viral load clearance is shorter with these 14 days treatment combination in the treatment arm, 17 days compared to 20 days. And also, if you look at the other parameters, is associated better outcome in terms of Apache score, in terms of the mechanical ventilation and vasopressor and renal replacement therapy. And again, it highlighted that if you're able to enroll the patient early on from shorter than 7 days, the outcome will be much better in terms of the using the combination. So let's quickly talk about immunomodulators, which again very important for the treatment, especially targeting and delay presenters who are admitted in the so-called second week from symptom onset. And this is of course a plasma therapy that had been widely used before the era of antibiotics. And of course, this has been used to treat various kinds of viral and even bacterial infection before the bacterial antibiotics era. And of course, lately have been used to treat SARS, swine flu, H5, and also with the COVID-19. And this is, of course, the paper by Thomas Luke highlighting the use of, at that time, convalescent plasma, looking at the use of plasma and Spanish flu associated with better outcome on mortality rate of 16% versus 37% with the control. And subsequently, of course, we did study of this on influenza or the swine flu using IVIG and also using the convalescent plasma, showing similar result that is able to associate better clinical outcome and also suppressing both the viral load and also the cytokine interleukin-6 and interleukin-10 in the patient who are given convalescent plasma in the treatment of severe swine flu infection. And of course, this meta-analysis showed beneficial results on those various trials on using the convalescent plasma hyperimmune IVIG in the treatment of respiratory viral infection compared to just one study who was shown to be of a harmful effects. This was, of course, repeated by John later on, and also by Thomas, and also subsequently by Mike's group, that in using the plasma, again associated with better clinical outcome, 2% versus 10% mortality in a multi-center trial in the treatment of influenza, severe influenza, using plasma and subsequently using IVIG. And of course, this is very much headed by the Mayo Clinic in the States, that they again enrolling a huge plasma study as a result, because they have so many donors, plasma donors, convalescent donors. And of course, they have already enrolled more than 100,000 patients, 90,000 infusion, and very much looking to the result from this trial. In Hong Kong, of course, we have been harvesting convalescent plasma. Although we are very much limited by the number of donors that are available, especially we are limiting that to male patient because of the rare and yet detrimental effect of recruiting female patients who have been pregnant, who have had pregnancy before, and associated with the HIV antibody from the fetus still present in the mother's blood, and hence causing a detrimental effect because of HIV antibody given to the patient. So we are just using male patient weight above the age of 55, between the age of 18 to 60, with a large good venous access for plasmapheresis, and also with a good so-called no comorbidity and no long-term medication. Nevertheless, we are still very successful in recruiting, especially young donors, and this is one of the very generous donors who have been donating more than 5 times the plasma, and even though he's now studying UK and upon now returning for the Christmas holiday, he was also volunteered to donate more plasma after coming out from his quarantine. And then, of course, it's myself and also Dr. C.K. Lee, who is now the head of the Red Cross. In terms of the early study from China, it's been shown that the convalescent plasma have some beneficial effect in better clinical improvement in the severe group, Nevertheless, with the so-called all patients group, the effect is probably non-significant as such. Subsequent study, of course, from India failed to show a difference. Nevertheless, this group, the plasma level, the antibody level is much lower, of 1 to 40, and also given so-called twice daily as a 250 ml followed by 250 ml. So that probably may not be able to maximize the effect of the convalescent plasma. Subsequent, another study, a randomized trial in severe plasma, a very large trial, again, unfortunately failed to show a difference in terms of the mortality in the plasma versus the placebo group, even though the antibody level was exceptionally high in this cohort. This again probably may have been related to the day when the treatment was given, and that nevertheless, if you look at the data on those who were so-called early on 7 days or 14 days after intervention, the number of people who have mortality, and of course the so-called receiving invasive ventilatory therapy is significantly fewer, up to 14 days compared to placebo. The difference is, of course, is 30 days. There's no difference as such. And of course, we would have to need more data from this during this period of time, whether there are any other causes in terms of the mortality, and of course, what happened during the latter 14 days of these patients who are enrolled for the trial. Important, of course, is the other antibody, monoclonal antibody study. One of them, of course, is very promising, is Regeneron. That, of course, President Trump has received and lead to of course, a very prompt recovery. Nevertheless, we're still waiting the data from the result from the recovery trial. But this study, this cocktail is a two monoclonal antibodies derived from humanized mice and also from convalescent plasma, and it's a double antibodies. And this will be important to prevent rapid mutation escape as such. And of course, both are targeting against the spike protein. So the result from this trial will be very important, especially if, again, given early during the from symptom onset. Tocilizumab has two very contrasting results. One is a retrospective study from the Italian group showing that, but of course, limiting to very severe cases, there was an intensive care. Hence, they were able to show that in terms of clinical recovery, they are much better with the tocilizumab, which is an anti-IL-6 treatment, compared to that of the standard of care therapy. The other study, of course, carried out by the Boston group by John Stone, failed to show a difference. The difference between the study, of course, is that the Boston study was targeting actually enroll patients who are less severe, just oxygen desaturation, and not necessarily requiring intensive care. So the timing of the treatment is different, that they were given probably a little bit too early, and that will probably lead to some detrimental effect, including that, of course, the higher viral load subsequently increasing the viral replication, and of course that leading to a even higher or worsening of the hyperinflammatory phase as a result, response as a result. So again, we need more data for the so-called really severe group of patients to be treated with tocilizumab. Nevertheless, do be careful because the tocilizumab may have some other detrimental effect, including that of the proning the patient to subsequent bacterial infection and fungal infection because of the immunosuppression given to the patient. Lastly, of course, just briefly talk about the heparin therapy that have been studied by the Wuhan group early on, in showing that the heparin use had been associated with lower mortality. especially for those who are much more severe with a high D dimers of more than 6 times the upper limit normal, and then reducing the mortality by about 30%. This was, of course, subsequently repeated by another group, again, a so-called retrospective analysis from the New York group showing that the anticoagulant is associated better inpatient survival with a lower mortality of 29.1% compared to 62.7% in this very large cohort, both in those with all patient and also those with requiring mechanical ventilation. The hypothesis, of course, is that the heparin itself is able not only to prevent thrombosis lead by the viral infection and sepsis, and also that it has some antiviral effect, able to block the viral entry, and also that is able to have some anti-inflammatory effect by dampening the pro-inflammatory signaling. Nevertheless, do have to watch out for the adverse effects for heparin, especially the 10 to 15 bleeding risk and heparin-induced thrombocytopenia. And that, of course, that these kind of risks are higher in Asian population because in general, the blood is so-called thinner and less able to clot in the Asian population compared to the Caucasian population. And this is, of course, the ongoing heparin trial, more than 20 of them in COVID-19, including that, of course, using the nebulized and then inhaled heparin for treatment in this various cohort of COVID-19. So conclusions is that for antiviral treatment, I think we need to have much more robust multi-center trials with similar kind of ICU support and similar kind of clinical setting or infection control setting in order to compare the results. Very, very important is the early commencement of combination antiviral treatment. That the antiviral is going to work only in patients who are given the treatment early enough in the first week, which are able to suppress the viral load and hence able to reduce the subsequent cytokine storm and hyperinflammatory reaction. And best, of course, is to give the combination. Could be at interferon beta-1b, remdesivir, interferon beta-1b with ribavirin or Kaletra, plus or minus dexamethasone. And if patients who are slightly late presenters and unable to control the inflammatory reaction, then of course the dexamethasone will be very important, very useful to control. And you can give that maybe just over a period of like 3 to 6 days of 10 milligrams daily, and then subsequently wean to 4 milligrams or 5 milligrams daily to control the cytokine storm. And we have been using that in both our triple combination trial and subsequently, of course, now using in our clinical treatment with very good effect. And by using that, and if you give the treatment early on, you are able to prevent subsequent deterioration and hyperinflammatory response. And of course, the study should be focusing in high-risk population, elderly group, those with comorbidity, especially in the patient with diabetes and patient who are immunosuppressed, in targeting these antiviral treatment, and again could be combined with convalescent plasma or other immunomodulators. Important, of course, we need profile in viral load and also inflammatory markers in order to clearly illustrate the response to these treatment, and also to tease out those the beneficial effects in the various stages of these patients who are presenting to us. And of course, we need novel antiviral therapies targeted at various sites of this COVID-19 in future trials, and of course, including that of the combination of monoclonal antibody cocktails. So I'd just like to finish off, of course, we need very close collaboration in the various institutes and also universities and parties of the world. And of course, again, I try to use the theme song of my favorite football team, Liverpool, that you will never walk alone. And only with these collaboration between the clinicians and of our lab scientists and also the various researchers that we are able to combat successfully against the COVID-19. And of course, even with the vaccine available, I'm sure that these antiviral treatment will be very important in the future, because the antibody will certainly drop after vaccination. And this will be very similar to that of other respiratory viruses, including influenza, that also have the vaccine available. But the virus will keep on mutating and the antibody will drop. And just finishing by acknowledging all the various frontline healthcare workers in Hong Kong and many parts of the world, both in HA, the hospital authority, and also in the Department of Health, that they have been working most diligently and very dedicated for the past 12 months. And of course, also have to thank our colleagues who are behind the scene working in the various labs, and my sincere gratitude to them. And thank you very much for your kind attention. I welcome any questions. Thank you.